My name is Dr. Elizabeth McIngvale. I'm the director of our program here at OCDI Texas. We are one of the few OCD and anxiety specific residential programs in the country. So all we do and treat is anxiety, OCD, and related disorders. We're so excited to get into today's topic. I am somebody who at times I'll use I, and that's because I do have lived experience with OCD, but I'm a clinician. I've been a clinician for many years. I also serve on the board of directors of the International OCD Foundation, do a ton of advocacy, and of course, my passion is for helpful, appropriate, evidence-based education. So really excited to be here, and I'll let Ryan introduce himself.
Yeah, I'm also very excited to be here and very excited for the launch of this inaugural webinar series that we're going to be doing throughout the year. We are, as Liz said, extremely passionate about treating anxiety, OCD, and related disorders here at the OCD Institute of Texas. We're both very involved in the community through IOCDF and other advocacy agencies. And we just live and breathe this work and feel so passionately about being able to change people's lives through the work that we can all do and making that better and better and sharing resources, sharing strategies, sharing all of the important information and the kind of breakthroughs in the field with you guys through this webinar series, what works and what doesn't, what the evidence says and doesn't. And I'm the clinical director here. I've been trained in CBT and ACT and ERP, been doing this for a while, working with individuals, both adults, adolescents, and children, and a lot of family work with parents and couples. And so we're very excited to be here with you today.
Yeah. So many times you will see Ryan or myself hosting these webinar series, but we will also be bringing on both clinicians that work here with us and of course external clinicians, because it's our goal that we bring in experts from across the field, so whether we're bringing in, Dr. Storch to talk about kids or Dr. Bramwitz to talk about inhibitory learning, we will definitely be bringing on experts throughout our webinar series. So we encourage you to let us know if there's certain folks you want to hear from, certain topics you want to hear about, so that we can make sure we're curating that education information and helping get it out there to the public. Of course, our goal is that education should always be free. It should be accessible. So after today, you will get the recording of this webinar series, and you'll have the opportunity, of course, to share it with anybody that you want. Our goal for today is pretty simple. We are really going to cover OCD and the foundations of obsessive compulsive disorder. So we'll start with a few slides. This is not going to be mostly we're going to be chatting and it'll be interview style. We have some questions that have been submitted and that we have written down when you see us asking each other those, just to do an interview style. But we are going to go through just some of the basics to make sure we're on the same page about what is OCD, what does it look like clinically, and what is the most effective treatment and why. We will have lots of time for Q&A, so we encourage and ask you to put questions that you have about OCD, OCD treatments, differentials, all things related in the chat throughout today's presentation, and we will be sure to spend the last 15 minutes or maybe even more going through questions, because our goal is that these webinars are always live, that they're always interactive, and that they're here to serve your needs. So let's get started.
All right, so as Liz said, the goal is really to kind of explain OCD from a clinical perspective, and then get into the foundations of ERP, exposure with response prevention, and why it is the only gold standard intervention for OCD. And then we're gonna switch over to some questions and really try to focus a lot on the kind of common misconceptions that not only patients and family members have, but also a lot of clinicians, especially if you're newer to treating OCD and anxiety, can have about OCD and ERP. So we really want to try to highlight a lot of those things, because I think that that's going to be really helpful for people out there treating OCD.
Absolutely. All right, so what is OCD? I think this is a question we get all the time, because as you know, what the media and or what even the world portrays or understands as OCD is often what we get really upset by, right? Because it's not often the case. But OCD is made up of two things: the obsessions and compulsions. Obsessions, which is so important to note, are unwanted intrusive thoughts. These are not thoughts that the person likes, that enjoys. In fact, these thoughts bring them distress. They are disturbing. They go against their morals, values, and belief. It's really important to note these are unwanted intrusive thoughts. And then, of course, the compulsions are better defined as repetitive behaviors or rituals that the individual does not enjoy. And this is also really important. One of the big differentiators is lots of people have obsessions, lots of people have compulsions, but what makes it OCD is when the obsessions are unwanted and when the compulsions are done in an effort to get rid of that obsession, to get rid of the distress, but they're not enjoyable, right? So no person with OCD enjoys doing their compulsions. They simply do them because they feel like they have to. In fact, most people with OCD will say things like, I wish I didn't have to do this. I really hate doing this behavior. And the thought of having to do these compulsions, they really dread.
Yeah, I think it's, the C in OCD is really important to keep in mind when you're questioning, is this OCD or not? Compulsion, compulsive meaning I feel as if I have to do this. I have no
Yeah.
choice in the matter. I don't want to do it, but I have to, right? Versus someone who, has behaviors that they enjoy or they find valuable or that they enhance the quality of their work or it's a preference, right? Those are not compulsive. Those are preferences. Those are choices. OCD, the C in it is very, very key. I don't want to do this, but I feel as if I have no choice. I have to.
And the one thing we didn't point out, which we will get more into later, is that these compulsions can be external or internal. I think there's a lot of misconceptions or understanding around mental compulsions. A lot of people miss these, but this is a huge part of the diagnostic criteria. Some people with OCD actually do no external compulsions, but they're doing mental rituals all day long, and that serves the cycle the same way. So what we know is that OCD affects about 2 to 3% of the population worldwide, and it takes about 12 to 17 years for individual to get appropriate effective treatment, meaning evidence-based treatment for OCD from when they start to have symptoms. What we also know is that exposure and response prevention, also known as ERP, plus evidence-based medication, which is often an SSRI for OCD, is the best, most effective intervention. Today, we're not going to be focusing on medications. We will absolutely be bringing on a leading psychiatrist soon to do that and to talk more about the most up-to-date medication and what that looks like for OCD. We're going to focus on the behavioral intervention, which I do want to point out. Psychiatrists and psychologists don't always agree with a lot, but universally, they all agree with the fact that if you had to choose one or the other, you would always choose ERP. And that doesn't mean you should choose one or the other, but the point of understanding that is that ERP is critical in the treatment intervention for OCD. You cannot do medication alone. You cannot do often other interventions. There has to be this behavioral intervention that we know ERP is what makes the most sense.
And oftentimes the medication is the usefulness of it is to help the person engage in ERP,
That's right.
to
Yeah.
engage in the therapy, because we know that for OCD really to not be a problem for the person anymore, there has to be a real shift in behavior and the way and a total elimination of the compulsive behaviors. Medication can help you activate that behavior change.
That's right. So when we think about the OCD cycle, it's actually pretty simple, right? Individuals have these obsessions, these unwanted intrusive thoughts, which you'll see that upward arrow, it increases and causes anxiety and distress. As their anxiety and distress goes up, they want to feel better. They don't like the way they feel. They don't like what's happening. So they engage in this compulsion, this ritual that's either internal or external. And when they do the ritual, they actually do feel better, right? The anxiety goes down. The problem with that is that that relief is temporary and it reinforces the cycle, right? Oh, every time I get an obsession, I need to do a compulsion to get better. And before you know it, it's disruptive, it's disabling, and they meet criteria for OCD.
Exactly. And the compulsion, as Liz said, the interesting thing is that it does provide some relief, sometimes a lot of relief, but over time, the amount of relief that it provides tends to diminish.
Yeah.
And sometimes it stops providing any relief at all. It's almost like a drug. You take it and initially it has a very large effect, but then over time you need more and more and more. So the rituals increase or the intensity of the rituals increase with little relief, and it often diminishes over time. We talk about the OCD cycle as obsession causes compulsion. Patients will come in saying that I don't want to be doing these things, but I have to because of the obsessions. We like to talk about the cycle in reverse as well, which is, when patients ask, well, why am I having all these obsessions? You're having the obsessions because you're doing
That's right.
compulsions.
You're maintaining the cycle, right?
Exactly.
Yeah.
And I think we can talk more about that later on, but it's very interesting to keep that in mind as a clinician, that the compulsions are really in some ways also causing the obsessions.
That's right. And the piece that I didn't put on there, which I should have, but we will talk about when we get to this kind of interview section in a second as well, is avoidance actually plays just as big of a role as a compulsion. So sometimes patients will start to avoid putting themselves in triggering situations so they don't even feel like they have to do this compulsion. And that again reinforces the cycle. Avoidance is really important to be thinking about and talking about as a clinician. Otherwise, you could be missing a lot. Some of our actually most severe patients may not be doing that many compulsions because they're avoiding interacting
Yeah.
with life and they've withdrawn from so many activities.
Yeah, as you're saying that, so if I'm like, yeah, avoidance is like the big word. It's almost like
There.
OOAD, obsessive avoidance
I
disorder. I
know,
mean, that's almost some of our patients for sure. Yeah.
totally.
Yeah.
So there are so many forms of OCD, and you'll hear clinicians and a lot of us talk about like, does the type really matter? And the answer is yes and no. It doesn't matter in the sense that like the content of your obsessions and or compulsions is kind of irrelevant when we think about OCD and what maintains it and how to address it. But what it is relevant for, especially, is diagnostic criteria, right? Is a lot of people with certain forms of OCD are getting misdiagnosed, or there's a lot of shame and guilt around their type of symptoms that they're not talking openly about it. And it's perpetuating that length of when somebody gets an appropriate diagnosis to appropriate treatment. And so, depicted in the media, most people think of OCD as our top two we have listed here, right? Checking and contamination. So someone going back, checking the locks, engaging in a lot of hand washing and contamination as the kind of what OCD is, but it's actually so much more. It can show up in the form of scrupulosity, which is some of actually the earliest documented OCD. And, in the early, I think, 1800s, when we talked about individuals being scrupulous, right, where their religion and their faith, their OCD and anxiety was starting to play a role and it was taking them away from their faith, right? But OCD starts to impact your faith and religion. Perfectionism and what we call just right OCD, some somatic OCD symptoms, violent intrusive thoughts. So these fears of like it can be harm to self or harm to other fears, very common with OCD. And then, of course, sexual intrusive thoughts. These last two tend to be what we call the more taboo types, meaning that sometimes patients don't come out and say it. You have to ask them about this and use appropriate measures like the YBOC symptom checklist, where you're going to ask specific questions about, do you have these obsessions or these compulsions? Because sometimes the shame and guilt would stop somebody from talking openly about it, but you need to know that. And guess what? It's so validating for a patient with OCD when you're asking them in this very nonchalant, like, very normal way, do you have these thoughts? A lot of people with OCD have these thoughts. They're like, oh my gosh, I didn't know that was my OCD, or I didn't. And so a lot of patients, not only does this happen in the therapy sessions, but it also happens online where they are researching OCD and they realize, oh, I'm not the only one with these taboo intrusive thoughts that are really terrifying to me.
Yeah, I would kind of, I'm sure you would agree, Liz, but in some ways, giving someone the diagnosis is a huge part of the
Yeah.
recovery process. Just that alone, especially if the person comes in not knowing that what they're experiencing is OCD, they're either number one, so ashamed of what they're experiencing that they're hiding it, like Liz said, or they're really believing it's real. They're convinced that like, oh, maybe I am a pedophile and this is horrible. So to hear like actually this is a really common thing, a lot of people have this, it's OCD. That right there, the diagnosis alone already starts the person well on their way to the recovery process.
100%. And I hear this a lot. I'll tell y'all, one of my biggest pet peeves is when I hear clinically, oh, the diagnosis doesn't matter. We treat the symptoms. You guys, that's not true. That is not true as clinicians. The diagnosis absolutely matters, especially, I mean, in the context of any mental health disorder, but with OCD, there can be comorbid and multiple diagnoses. We need to know everything that's going on, because why? We can't treat people. You can't use evidence-based interventions if you don't have a diagnosis, right? That's not possible. Why? Because different diagnoses have different evidence-based interventions. So we do need to know the diagnosis and what's going on.
Exactly. And people feel inherently, in a good way, so reassured getting the right diagnosis because it helps them make sense of what they're experiencing. When we have a medical problem, we go to the doctor, all you want to know is, do you know what this is? Can you tell me what it is, right?
You treat it.
And can you treat it?
So that
Exactly.
leads to our second point, is when we know what's wrong, we can talk to patients about how it's treated and what that can look like. So we won't go through all of these, but common obsessions can range, right? But overall, these are these unwanted intrusive thoughts that can, again, be focused on harm. They can be focused on faith. They can be focused on worries of contamination, all sorts of things. But this is a tiny list of what obsessions can actually be, but there can be, countless and endless. And the same with compulsions. Some compulsions are more obvious, like checking and hand washing, but we see lots of self-reassurance, mental reviewing, excessive prayer, all these mental rituals nowadays, right? Chat GPT and all these other ways that we see compulsions coming in, but this list just barely touches the surface because, again, compulsions can show up in a million ways, but it's all about, is it maintaining that cycle?
Question for you. Would you say that you could have OCD about anything?
Yeah,
Yeah,
definitely.
right.
Yeah, absolutely.
Yeah. So
Uh,
even though we have these like categories, which are very common, I mean, we've seen very, very strange, niche,
yeah.
super specific OCD about very random things. And I'm sure, and it feels like we've seen it all, but we haven't.
Right, right. Absolutely have not. Every patient is something new in different ways, even
Yeah.
though it's similar, right? And that's why we say content doesn't matter because, again, if it meets diagnostic criteria, it can look different, but the treatment's not going to change, right? But you should never, we'll talk about this later, but you should never have a standardized treatment approach. It has to be individualized. Why? Because it needs to be tailored to that patient, but you need to know how to tailor the approach. You need to be confident in that, and that's critical. So yeah, we know that OCD symptoms are often misdiagnosed. Why? Well, because most patients go to primary care physicians, their church leaders, or local mental health clinics as their first stop when they're struggling. And those providers are typically not super well educated in OCD, right? If I took a poll, which many researchers have done of, clinicians, when they become a clinician, what was their training like on OCD? It's very minimal. Most people would say, oh, I learned about it in my DSM course, right? Like by reading about it, but there was not specific training and understanding of the treatment and or the disorder and the diagnosis. And so we see these diagnostic challenges. And a part of the reason is that these taboo thoughts or these like, non kind of typical OCD thoughts, we see how common they are, right? Like you see the percentages that show some of these taboo thoughts are very, very common in OCD, but a lot of providers don't actually know about them. They don't know how to identify those as OCD. And then, of course, we see lots of common misdiagnosis. One thing that we see a lot is like BPD being misdiagnosed as OCD. And then, of course, we see a lot of like OCD being misdiagnosed as GAD or being misdiagnosed as something else, So we see it go both ways all the time.
Yeah, and there'll definitely be some future webinars exactly on this topic of differential diagnosis and how to manage that.
100%.
Okay, so the treatment for OCD is very clear. There is one treatment for OCD that is the most evidence-based, really the only evidence-based treatment for OCD. And the good news is that it's very, very effective, right? We're actually really lucky and fortunate in the treatment of OCD and anxiety disorders that we have a treatment that is so highly effective. A lot of reports say up to 80% effectiveness rate. And we have our own theories about that 20%, that remaining 20%, why that is. And I think that if you actually have an accurate diagnosis and you have a good treatment plan, you understand OCD, you can get a lot closer to 100% effectiveness rate. But the treatment is exposure with response prevention, ERP, which we're going to talk a little bit more about today. However, the caveat, and we like to say this a lot, is it's ERP within the framework of CBT, cognitive behavioral therapy. So really, if you're doing ERP, it should be coming through the lens and the framework and the theoretical foundations and understanding of cognitive behavioral therapy in which it was developed. And so ERP really only makes sense if we're thinking about it from that CBT lens. When you do that, you will see people's OCD really kind of melt away pretty quickly, especially if they're motivated to do the work. So
with my training and even the way we train our fellows here, like our focus is really strong CBT foundations first, and then moving to training individuals on ERP. And the reason for that, as Ryan is saying, is that if you don't have a strong CBT foundation and you're learning just the tenets of ERP and it's kind of like, oh, this is just how I'm supposed to do ERP, but it's not generalizing for you, it doesn't make a lot of sense. You will get stuck, right? When you have a unique patient or someone with a comorbidity that it better is explained as panic or as GAD, and you're like, well, ERP specifically isn't working. It's like, well, yeah, because CBT makes more sense. So you have to understand the foundations and the principles of CBT. And if you do, ERP makes a lot of sense.
It makes perfect sense. Exactly. Exactly. And then, of course, the medication piece of this, which we won't get into too much, but SSRIs are the first line intervention medication-wise for OCD. And then, of course, consult a psychiatrist for kind of the guidelines above and beyond that. We will do a webinar specifically on psychopharmacology for OCD in the future.
Right. I do think the slide needs to be updated, so I apologize with some of the meds, but what I will say is if you go to iocdf.org and type in treatment guidelines, those are always the most up-to-date guidelines on both behavioral interventions, the first line and why and what it looks like, as well as medication. And we are not going to go into that, but we will definitely have people on in future episodes that'll talk about how to disseminate research, how something becomes evidence-based, and why that's the case for ERP, why it's the case for, medication. Today, we're going to dive into what ERP actually looks like and focus much more on that, but we will definitely be doing more webinars. But the International OCD Foundation really helps guide our foundation and is the scientific advisory board through the IOCDF helps guide those treatment guidelines. It comes from sound research, amazing clinicians, and should be a well-trusted resource for you if you're wondering, hey, what's the latest information on meds? What's the latest information on behavioral therapy? Oh, I heard about this new intervention. Should I be doing that before ERP? Go there first instead of just trying something new.
More on ERP. So there was a fairly big shift in kind of how we do ERP to some extent by kind of incorporating this idea of values-based ERP, which we'll talk some more about today and also more in the future. But ERP in kind of the older, more traditional way of doing it was, well, we just need to, if the person is afraid of this, we need to just evoke as much distress as possible around that particular fear or obsession, and then have them not do the rituals or avoid, which can work and can be useful. But what we find is patients are much more bought in, much more motivated intrinsically if we're saying, hey, let's do some exposures. Let's face your fears around things that you care a lot about, like your children, like your work, like your hobbies, like things that you want to be doing, travel, all kinds. Because we know that OCD, especially when it gets to that moderate severe level, it is impacting almost every aspect of a person's daily life. Sometimes the obsessions are happening literally 24/7 as long as they're awake, having dreams about them too. We hear that all the time, right? So if we can make ERP really target the things that a person cares about, that they're kind of sacrificing because of their OCD, the ERP is going to be so much more effective. The patient's going to be way more motivated to do that.
Yes.
And so it's not just distress for distress sake. It's distress so that you can live the life that you want and you can be more involved in the things that you care about.
And one of the big reasons for this, again, if you just kind of think about it in a more like holistic, generalized fashion, imagine if a patient like does ERP and they get better, but they're not living their life, right? What's going to happen? OCD symptoms are going to show back up. So like again, we are doing ERP that's getting them back to living a life because the more patients engage with their life, the more they have a reason to keep fighting their OCD and to make OCD get smaller, right? We want life to get bigger, OCD to get smaller, not OCD gets smaller, but life doesn't change because now it's like, okay, well, when they have their next trigger, it's going to be really hard to not engage in it, but so much easier to not engage in it if they're working, if they're at school, if they're with friends and family, and they're like, no, I don't want to let that get loud again, you know? So values-based ERP also it kind of does two things, at once, which is nice. You're obviously addressing OCD, but you're helping patients re-engage with life.
Exactly. Yeah. And we say that a lot, that ERP, while it is the intervention that treats OCD, and if a patient does ERP, they can overcome their OCD and get better. It also is quite its own personal achievement for someone because they are quite literally facing the things that are most terrifying to them and showing themselves, demonstrating through the exposure work that they can face difficult things, that they can experience difficult emotions, and that they're stronger than that and they can move forward. And when people experience that, it's so profound. It's such a profound experience. It really changes in a lot of ways who they are as a person and how they
Yeah.
think about themselves. We oftentimes see people come through, they're coming for treatment of OCD, and then in the middle of the process, they're gaining all this confidence. They start to say, I want to make these other changes in my life too
Yeah.
that have nothing to do with my OCD because look at how capable I am.
Yeah.
Yeah, empowerment really, when you're doing ERP, what you're looking for, if you know you're doing it right, if the patient is feeling more empowered,
Yes.
they're speaking in a more empowered way.
And by the way, you can I we can go to live now, which is exciting, but I always like to give two examples and three things I want to talk about today. Number one, be really thoughtful when you're treating OCD and thinking about the treatment of OCD, both with your patients or if you're a family member of like, are you fragilizing that individual with OCD? Are we creating a belief system in them, but also do we have our own that, oh, because they have OCD, they can't do the things that we would expect or want them to do if they didn't have OCD? And what negative impact that could be having on their life. ERP teaches individuals that you can do hard things and that you can get back to life. And by the way, you guys have participated in ERP. We either pushed people, even if you didn't realize it. This weekend, my 5-year-old, my daughter Olivia just turned 5, and she learned how to ride a bike without training wheels. And it's such a perfect example of ERP, right? She's terrified. She's crying. She doesn't want to do it. My husband's like, no, you're going to do it. I'm kind of like, I don't want to deal with this. Like, I don't really want to force her to do it. But he's like, no, you have to learn and you're going to learn. And guess what, guys? After an hour or so, she was riding independently. And now all she wants to do is ride her bike, right? She's so excited and so empowered. She's told her teachers, she's let everybody know. She's every day we're riding bikes now because she's so proud of herself. You are teaching ERP, you're teaching CBT skills, even if you don't realize it, from childhood, right? From
Yeah.
from birth, you're teaching individuals that you can do hard things. And what happens when you do something hard, it's not just, oh, you did something hard. You feel good about it. You feel empowered, right? Most of us, when we think back on some of our biggest accomplishments in life, they didn't come easy, right? They came through pushing through perseverance, but like also through facing difficulties. So think about that when you're thinking about ERP and understand that's a part of the model.
That brings up two questions I want to ask you that I think are really important. So let's pretend I'm a patient. I've come to you. You've identified that I have OCD, or maybe I knew that already, and I came and I said, two questions for you. We get these a lot, right? Is OCD curable? Can I be free from this?
Yeah.
And I'm terrified of doing ERP. How would you explain ERP to that patient? So let's start with the first one.
Yeah.
First, the big question, which we get a lot from clinicians, from patients, from family members. Can I be free from OCD? Can I get rid of this?
Yeah. Yes. And this is something that for some reason has become controversial, and I don't know why, right? But I think the word cure scares people because it feels like it's more medical and that it kind of makes people think, oh, there's like this pill I can take and I'm going to be cured of OCD. And we know that that isn't the case. But can you be free from OCD? Absolutely. And I'm not saying this just as a clinician who treats OCD, but as somebody who lived with severe OCD, went residential myself when I was 15 and has struggled for many, many years. And I actually will tell you, I'm somebody who did ERP, did it well. I was way more functional after my first good dose at residential, but I wasn't free from OCD. And I spent a decade or more of my life thinking that the best I could get was learning how to function better while struggling. And mind you, during that time, I went to college. I was, from the outside, people thought I was doing great, but I was still struggling. I was often white knuckling. I was often still engaging in rituals and still holding on. And I had to learn that the principles of ERP never changed. They weren't going to change, but it was my willingness to use them in a way that was going to get me freedom. Was I willing to address my core fears? Was I willing to let go? Was I willing to use ERP to get me to freedom? And that's what us as clinicians should be talking about. Be careful using the old school language of like OCD is this chronic disease that you'll always deal with, but with effective treatment, you can learn to better manage your symptoms. I heard that for decades. And the problem when you hear that is that you start to sell your own recovery short because you think the best you're going to get is being more functional. You don't actually believe or know that having full freedom from this illness is possible. But again, if you really understand CBT, you can't not understand how freedom is possible, right? Because when you're really using it all the way, you've totally broken the OCD cycle. And we shouldn't have to break it for every symptom. We should be able to break it overall. And that's where freedom comes from.
Exactly right. And if we're thinking about, all of this from a CBT framework, we know that the beliefs that we have about ourselves, about the world, affect our behavior, what we choose to do and don't do, right? If I believe that exercise helps me be healthy, I'm more likely to engage in that behavior. If I don't believe that it's possible to get better from OCD, how much effort am I gonna put into finding a good therapist, following through with ERP if I just think it's just about like suffering a little bit less or having to deal with this for the rest of my life? Maybe I'll just get better at tolerating the distress instead of actually getting freedom from it and learning how to break the behavioral cycle. And that's the other point, right? Is that what's causing OCD? We don't know what initially causes it. That's still kind of a mystery. But the good news is we actually don't need to know the
Yeah,
original cause. We know what's maintaining OCD.
that's right.
And that is a series of very specific behaviors, the way that we're responding to thoughts, the way that we're responding to sensations in our body, and the behaviors we're doing as a result of that. If we can disrupt that cycle and replace it with something more adaptive, the OCD will go away.
Yes. And I think that's one of the problems, right, Ryan, is we see so many people who they think that the problem with OCD is actually the fact that they have these intrusive thoughts, right? It's that, oh, the issue is that I have OCD, that I have these thoughts, where it's like, yes, of course, like you didn't ask to have OCD, no one is saying that, but the problem is actually the behaviors that you're doing that are maintaining the OCD. It's not the thoughts themselves. And when individuals can understand that, even though I do see that this is a hard shift sometimes for people to understand because for some patients it feels invalidating that you're saying that like I'm choosing to keep OCD. Of course it doesn't feel good and it's like, well, you didn't choose to have the disorder, but we do need patients to understand that the behavioral actions that they're doing that are reinforcing their OCD cycle are a choice. Because guess what? The power is in that. that's where all the power lies. If you recognize that I am choosing to do things that are maintaining my symptoms, not because I want to, right? Not that it's an easy choice, but like that it is a choice and that I can choose to do something different, which can totally disrupt the cycle. That's where the power is, right? The power is in the behavior change.
Exactly. And that is why we're very, very firm believers in the power of psychoeducation, and that psychoeducation is an absolutely crucial step in the
Yes.
treatment, and that it cannot be glossed over. You should not rush it. Don't rush right into ERP. What is the point of psychoeducation? Not just so that the patient understands what's going on, but so that you're on the same page as your patient on what is the actual problem.
Yeah.
Is the problem that you have your brain does things differently and it's always going to do that, and you just need to learn how to cope with that? No, if the
Mhm.
patient thinks that's the problem, they're not going to get better,
That's right.
right? If the patient understands the problem the same way that you do, which is, hey, you're interpreting these thoughts in a way that's not helpful. You're responding to these thoughts and feelings in a way that's not helpful. We have some other ways that we can suggest and practice with you of responding. And when we do that, you'll see how much better you're going to feel and how much more functional you're going to be. If the patient can come alongside you and see the problem the same way that you do, then we're ready to start the real treatment, the
Yeah.
ERP. But you cannot gloss over psychoeducation. The point is really to make sure the patient fully understands what the problem is and what it's not.
Yes, 100%. And so my first question for you is like, what are some of the biggest misconceptions about OCD, maybe in the public, but even among clinicians? Like I think we see a lot of times a lot of different things where we're like, okay, like this actually isn't OCD, or we're like, no, that definitely is OCD. But what do you feel like are some of the biggest misconceptions that we need to help address?
Yeah, I think with the general public, there is still, unfortunately, the way people use this word. I hear it all the time.
Yeah.
I don't even address it anymore because it's just so common. I was at Target the other day, and the I had my OCD Institute shirt on, and the cashier said, "Oh, you treat OCD?" I said, "Yeah," and she said, "I have OCD," and then she starts to tell me all the like quirky things she does. I'm really, I like to organize the closet and blah, and I'm like, okay, it's not worth explaining
You
why.
have the time at this
Yeah,
checkout stand to explain the truth here or not.
I'm
Yeah.
not going to change this woman's mind. But yeah, there's still this kind of misconception quite
Yeah.
broadly in the general population and within clinicians as well, who are not super familiar with this, that OCD is something that people do because they like to be really in control of everything, and it's just looks like being really organized and type A. Or particular about certain things and maybe a way that's annoying to other people. And that's just absolutely not OCD. OCD is a very, very specific thing. And what's interesting is, like we said, it could literally be about anything. It could have absolutely nothing to do about things being a certain way or being
Clean.
clean,
Yeah.
right? Like even contamination OCD, which when you hear that, you think something about cleanliness. It actually has nothing to do with
Yeah,
being
it may
clean,
have
right?
nothing. Yeah, that person might
Um,
actually have a very dirty house, but they have
yeah.
severe contamination, right?
Yeah, so I think that misconception is still, it's going to take a lot of education. It's going to take a lot of time, a lot of shift in media. I think as more movies and shows come out or, reels and stories online about what real OCD is, I think people will then start to shift in that, but it's going to take a long time.
It's going to take a long time. Yeah, I used to run a nonprofit called the Peace of Mind Foundation, and one of the big things we always focused on was education and advocacy. And I remember I was sitting around the kitchen table with my sister. She's creative, I'm not, and I was like, Laura, like, I need a slogan to help people address the misconceptions. And she came up with a slogan that's like been more widely used now, which is great, which is OCD is not an adjective. And I think that's the most important way for us to address misconceptions is when people are saying things like, oh, you should see my coworker's desk, she's so OCD, or you should see my mother-in-law's kitchen, she's so OCD. That's probably not OCD, right? That's probably preferences and quirks and tendencies. And most of the time, those people will talk about how these behaviors actually help them function better, right? That they're useful. Like, oh, that allows me to like stay more organized and to like stay on my to-dos. And it's actually something that makes me feel good. Very different than OCD, like we talked about
Absolutely.
earlier.
And then, the biggest misconception I think I see with clinicians who are unfamiliar with OCD is that they will kind of hear the obsessive part in OCD and think that any obsessive like behavior that they're seeing in a patient must then be clinical obsessive compulsive disorder. And that's just really not the case. Even the C in OCD,
Right.
other disorders can have compulsive elements in them.
Yes.
It doesn't necessarily mean it's OCD. You can have a patient who's very obsessed, they're preoccupied with something that's on their mind quite chronically and frequently that causes distress. It doesn't necessarily mean it's OCD. For OCD, we're really looking for obsessions that are bizarre or magical in nature, kind of with catastrophic implications. And then all of their compulsive behaviors are directly linked to trying to make those thoughts go away or prevent the thing they're afraid of from not happening. It's a very tight, well-defined diagnosis. There are things that look like it, like body dysmorphic disorder, for example, looks like OCD, but it is about appearance flaws or perceived appearance flaws. The diagnosis matters. Calling it OCD about appearance is not going to cut
No.
it because the treatment actually does. There is some overlap, but there's also a lot of really important
Very
differences.
important difference, which we'll do a whole webinar on BDD that Ryan will
Exactly.
lead. But
Yeah.
yeah,
So
very important.
diagnosis matters. And if you're not super clear on OCD, we want you to do webinars like this, do trainings, get more information because it really is very important in terms of patient outcomes.
So one of the things we hear thrown out around a lot, especially for clinicians, is the difference in something being egosyntonic versus ego-dystonic. First of all, can you explain to non-clinicians the difference between egosyntonic and dystonic, and why and where does this play a role in the OCD cycle?
Totally. I'll go right into I think the big misconception with hearing egosyntonic and ego-dystonic, there's a simple way to understand it that I think a lot of people use, which is egosyntonic means I enjoy this, ego-dystonic means I don't. And that unfortunately, that is just not a very accurate way to think about this. It is a little bit more complex and nuanced. So egosyntonic means that whatever thought I'm having or belief that I have feels like it's a part of who I am, a part of my sense of self, it's aligned with my values, who I want to be. And so I kind of welcome it. I don't fight against it, right? We can have egosyntonic beliefs that cause us distress, just like we can have, ego-dystonic beliefs that don't, and vice versa. So it is a little bit more complex, but egosyntonic means something that I agree with, that I view as part of me and part of who I am. Ego dystonic is something that I don't like. I don't want to be a part of me. It feels alien to me. It feels against my values. And oftentimes it causes distress. Oftentimes ego dystonic things cause distress. But there's probably examples where that's not the case. So you don't want to simply apply this. Does the person, do they like this or not? Although with OCD that usually can work. But intrusive thoughts, which obsessions are often in the form of intrusive thoughts, we label as ego dystonic because the person will say, I don't want to be thinking these things. I don't agree with these thoughts. I want to make sure this isn't true about me.
Hate them, make them go away,
Exactly, exactly.
Yeah, this is, and by the way, people with OCD, it doesn't mean everything is ego dystonic. I always it's funny because growing up, I'm somebody who does like things very organized, and like I find a lot of pleasure in that, and I like the way my fridge looks or my closet, and my parents would always label everything as my OCD, and I'd be like, this isn't my OCD. Like, this is something I actually enjoy. Like, I like the outcome of this. Even though sometimes it's annoying to do the organizing, I feel great after I did it, and I feel like kind of proud of myself.
Exactly.
I never feel that way or never felt that way about OCD.
That's a great way to differentiate, right? Like, why was the organizing and cleaning not your OCD? Because that was egosyntonic. Even though there were times when you
aligned
probably
with my values or my sense of
exactly,
self.
exactly, yeah, and
exactly.
feeling like you need to clean the house. Maybe you would rather be sitting on the couch reading, and so it is in some ways, it's effortful, but you want to do it. You want to be, or you think you should be doing it. Versus if it's ego
You feel
dystonic,
good after. It's like
you
the
feel
gym.
good after. Yeah, exactly,
To
exactly.
go, but it's good for me, and I feel good about it after, right?
Exactly.
So what do you feel like are some of the most commonly missed types of OCD? Like, what are the things you see most commonly missed?
Yeah, this is a great question because unfortunately, I think so many of the subtypes we looked at go missed, and I think the big thing is that people, if they don't know about the patient, if they don't know about OCD, they haven't been diagnosed before, they will come in talking about their obsession, and it will, to you, especially if you're kind of uninitiated in this world, you will feel like it is a real problem, right? The person comes in, I had this, I was, a thought about a child, and maybe it was attractive to me, and I'm so worried, what if I'm attracted to children? And a lot of therapists are like, oh my God, like, do I need to make a report? Is this person a danger? Or I'm so worried I'm gonna, hurt someone. And yeah, my mom made me really angry. And then I had this thought about stabbing her. And I'm so worried. What if
And why'd I have that thought? What does it
why'd I
mean?
have
Maybe
that
I
thought?
would do it, right? They'll say things like that.
Exactly. And so if you don't know about OCD, you can hear that and maybe go, oh my gosh, maybe I need to help this person, give them distress tolerance skills or anger management or something like that. And that can really, obviously, of course, make it worse. But some other ones that people miss a lot, I mean, I think scrupulosity. Someone comes in and their faith is really important to them and they start talking about problems they're having with their faith. A lot of people like, we have to
Think
take
it's a
this
faith
seriously.
problem
Yeah,
or
let's
send
talk
them
to
to
the
a faith.
priest. And sexual orientation OCD. I think a lot of times we want to be affirming of people and their identities. And so it can sometimes sound like, oh, maybe this person's just going through an identity crisis or they're questioning or they're ashamed of their sexuality. But actually, no, it's really just straight up classic OCD. They know their sexuality, but they're doubting it in a compulsive, pathological way. So that gets missed a lot. What are some ones you can think of?
I think one of the biggest things to just kind of note is if a clinician's on here who doesn't treat OCD frequently, who's saying like, well, how would I differentiate if they are questioning their sexuality versus sexual orientation OCD, or if this is a faith problem versus scrupulosity? The difference again often lies in that egosyntonic versus dystonic, right? Most patients with OCD will say something like, well, I know I'm straight, but I keep being triggered by this. And if you start to ask them exploration questions, it falls really awkward and like short with them because that's not where they're at. That's it actually will just trigger them and it's not something they're like, I'm wanting to understand myself, I'm wanting to explore, I'm wanting to better, right? Like think this through. They actually don't want to think about it. They don't want to talk about it because they're triggered by it. And but again, it's ego dystonic in the sense that it's not something I'm actually trying to understand, or there's not pleasure or enjoyment. It's I know that's not me. For the pedophilia stuff, like one of the things I'll often hear patients say is like, I would hurt myself before I ever did something. Like, and these thoughts are so disgusting. They go so against my moral belief that I just can't tolerate any uncertainty. I have to know for sure that I'm not that type of person. And if you were to say something like, oh, so like, have you ever been attracted to kids? They will say, no, absolutely not. Of course not. Why would you ask that? Right? It's very clear. It's like, but what if, right? If I've had this sexual intrusive thought, maybe it means something. Maybe I need to figure it out. Maybe I need to understand it. And by the way, they're having the same thoughts that people without OCD have. The difference is theirs have anxiety and distress attached to it. And so because of that, they then try to figure out what it means and they end up getting more stuck and have more doubt. And it just becomes this scary cycle for them.
Stuckness. I'm glad you used that word. I feel like you will know you're working with someone with OCD by the stuckness factor, which is that no matter how you talk about it, how you reason it out, how you try to problem solve it, the patient never seems to move forward, right? So if you actually did have a patient who was really going through, an identity exploration phase, I'm not sure about my sexuality, maybe I'm attracted to men or women or both. If you talked about it and you kind of asked them to explore in meaningful ways, they would come back week after week having, new information, new insights, or having more clarity or being able to move forward with that, right? With someone with sexual orientation OCD,
To interrupt you, would there be urgency if they were just
also would
exploring?
not be urgency, right? They would still be doing other things. It wouldn't be the only thing on their mind, right?
Right.
But exactly. So the urgency would be there, and the person would continue. The more that you talk about it with the person with OCD, the more you ask them to explore it, which they're probably already doing all the time anyway in a compulsive way, the more stuck, the more confused
More
they're going to
triggered.
get, the more triggered.
Yeah. But there's this urgency with OCD, right? It's not like, okay, yeah, let's talk about this, let's figure it out. And they don't have that ability to maintain that in this calm manner. It's, well, I need to know right now. Like, I know this isn't the case, but I had this thought and I need to know what that thought means, right? It's very different. It's about a specific trigger and it's urgent versus, oh, I'm willing to talk about this. And I don't seem to have a lot of anxiety and distress attached to it.
Yep.
So now I want us to transition to ERP because this is so important and obviously the bulk of what I want us to talk about. But before we talk about exposure and response prevention as the gold standard of treatment and why it is, I'm curious and I want you to answer this because I get this all the time. Are there types of OCD that don't respond to ERP? We hear this a lot, and so like, I'd love for you to address it.
If there are, I've never seen one. Yeah, no,
there's
no.
not.
Yeah, all types of OCD respond to ERP. The one you hear the most frequently, well, actually, there's a lot that people will say. I've heard that, oh, scrupulosity can't be treated with ERP. That's definitely not true. All the evidence points the opposite direction. It's absolutely treatable with ERP. In fact, that's the only thing you should treat it with. You also hear people talk about what sometimes is called pure O, where the person only has obsessions and not compulsions. That's actually not accurate. What they're talking about is they have mental compulsions. They're doing rituals, but they're in their mind. You can't see them, you can't observe them the way you could with like a hand wash or cleaning something or something like that. But even pure O, if such a thing exists, right, we're just basically OCD with mental compulsions. ERP is the same treatment because the response prevention piece is going to be we're going to do the exposure and not do your mental rituals the same way that we're not going to do observable physical rituals with any other type of OCD. Sometimes people come in with this misconception that, mental rituals I don't have any control over.
Right.
What do you say to that?
Oh, I say a lot to it. I think there's two things. The first thing is like you absolutely do, right? But the second piece is I also don't want patients to think, because I've heard this a lot in the field lately of like, okay, let's focus on rumination disruption and let's focus on like how you can just kind of move through mental compulsions or mental rituals and how you can just stop yourself from doing them. But again, we're going to talk now more about ERP, but if you're doing ERP and addressing the core fear, the goal is that we actually get rid of the urge to ruminate. The goal for my patients is that they have thoughts, but they no longer have triggers. And if we're really doing ERP, they should get there. And so the goal is not, oh, our whole life we're trying to just not do a mental compulsion. That would be like saying the same as external, that, oh, you're going to do exposures and just try to not ritualize. No, that's called white knuckling, right? Whether it's mental compulsions or external, it's the same. You're just trying to survive through it, but you're not actually getting relief because you're not doing all of ERP. If we do ERP fully, the mental compulsions will wipe away just like, and the desire to do them or the urge to do them will go away just like external ones. It works just as well. But as a clinician, you have to address it. And I think for those of you that don't do a lot of OCD work, a lot of clinicians are not talking about mental compulsions with their patients. They're not knowing to ask and screen for them. And so, yes, if a patient isn't identifying that mental compulsion as a behavior that's keeping their OCD cycle alive, they might be doing treatment, right? They're doing exposures and they're not doing external ones, but they're mentally ritualizing and they're not getting better. And they're wondering why ERP doesn't work for them. We know why it doesn't work for them because you're still doing compulsions. They're just mental compulsions.
Exactly. Important point to clarify, right? ERP works when the RP is present, the response prevention. So when we do an exposure, we approach something that we're afraid of, that is an obsession. If we approach it, but we're doing rituals and compulsions, the fear is not going to go away. In fact, it actually is probably reinforced and made worse.
Yeah.
And so if your compulsions are mental and you're doing ERP exposure, but you're still doing the mental compulsions, we wouldn't expect the person to get better. So this is another thing to look out for. If your patient looks like they're doing ERP, but they're continuing to say, I don't feel any relief, I'm not getting better, it's not getting easier, check in for the mental compulsions. I see we have a question about mental compulsions. This is great. So what are the best assessments when someone has mental compulsions? Two things, and you may have some others, Liz, but the YBox symptom checklist includes many of the most common mental compulsions on there. It'll ask about rumination. It'll ask about kind of chanting, praying, counting, reviewing, replaying things in your mind, trying compulsive reasoning to try to solve a problem in your mind, those things.
And remember, when you're treating OCD, yes, there's amazing assessments and measurements. So, like the Yale Brown Obsessive Compulsive Scale, you'll hear us referencing the Y box. There's also a PSI box, the Children Yale Brown Obsessive Compulsive Scale. That is an amazing 10-item measure just to understand, like, does someone meet diagnostic criteria and what is their level of severity? But it's also accompanied by what we call the Y box symptom checklist. And it has this wonderful list that you can go through of common obsessions, common compulsions, and what that looks like. But here's the thing. When you think about OCD, we are going back to CBT, which is that which means yes, if they have OCD, there has to be something maintaining the cycle. And so you as a clinician, you want to ask questions that would allow you to understand anything external or internal that patient might be doing that's maintaining the cycle, right? So I like to just simply ask patients like, okay, tell me about the behaviors. These can be internal behaviors or external behaviors that you do to feel better. And ask specific questions about mental compulsions. Are you doing any mental reviewing? Are you reassuring yourself? Are you telling yourself something to feel better? Are you replaying a past event to try to get certainty around it? You'll ask some of those leading questions that patients will often say, yeah, actually I am. This is what I do to feel better for this obsession, or this is what I do for that obsession.
Exactly. And this is where I think some newer clinicians, when you're getting into the OCD work, can find it a little bit tricky. As we said earlier in this series, you can have an obsession about anything. Anything can also be a compulsion. And so again, we could make a really good assessment for all the different mental rituals, but at the end of the day, it's about the function of the behavior. Why is the person doing this, right? So, we've seen people use ERP compulsion as a compulsion, right? So anything can become a compulsion. It's on you as the clinician to be kind of continuously assessing for what do I think, and helping the patient see themselves and learn to identify when am I doing something to try to make this fear go away? If that's the case, that's the compulsion. It
That's
doesn't
right.
matter what it is. But I'm looking at the
Yeah.
time. I think it'd be great if people want to put some questions in the chat. We'll keep kind of going through some of our questions too, but we'll also answer
Definitely.
questions.
And I don't know if we may have to hit everyone if there has been other questions in just to be able to see if there's any other questions. But yeah, put the questions you have. But let's hop into ERP. So Ryan, how would you explain in layman's terms to a patient, to a family member, if somebody said, well, what is ERP? What is treatment? Like what's the overall goal and what does it look like?
Yeah, I love the analogy you use, the example of your daughter riding a bike. I often use a kind of a simple phobia example with
Yeah.
people because they can understand that's very concrete. So I might ask them, when you were a kid, was there anything that you were ever afraid of? When I was a kid, I was really terrified of dogs. I don't know why. I never had a bad incident with the dog. They were always very nice to me. I didn't have a dog bite, but I was afraid of them. And I used to ask, like when I was going to go to a friend's house, I would say, do you have a dog? And if they did, I wouldn't go. Yeah. But so if you have a fear of something and you're avoiding it, or every time you're around it, you're doing something to try to stay safe, um, the only way to get over that is to actually approach it and learn that it's not dangerous, learn that it's okay. OCD, I think there's one way that we can conceptualize it as a thought phobia or a feeling phobia or an urge phobia, right? Because we know that obsessions can be thoughts, they can be ideas, they can be images, memories, urges, sensations. It could be really
Okay.
anything, right? And so that's what the person is phobic of. And so when you're afraid of something that truly isn't dangerous, right? Because that's the other thing. If someone comes in and they have an obsession about something very dangerous, that's not OCD, and we want them to
Right.
avoid doing that, right? They might be worried it could be dangerous or sound dangerous, but it's not. ERP is going to be, we're going to, at a gradual pace, expose you to the thoughts and feelings that you're terribly afraid of, and we're going to not do those rituals that you usually do. And you're going to see over time that you actually can experience those thoughts and feelings in a way that's very different from how you usually do.
That's right. What I always like to share is like think about it in a way of like we're going to approach your fears so that your fears no longer control you in any way. And I always love to caveat the fact that like ERP is something we're going to do together, and I would never ask you to do something I'm not willing to do. I'm not asking you to go put yourself in dangerous situations. I'm not asking you to lean into your worst case fear as being truth. Instead, I'm asking you to do things that all of us do every day, and we all take risks, right? We all lean into uncertainty, most of us unknowingly, right? We get in a car, we schedule meetings, right? We do all sorts of things that lots of uncertainty is involved, but we assume it'll be fine. We don't have necessarily a reason to believe otherwise. Patients with OCD, for the things they're afraid of, their tolerance for uncertainty around those fears goes away. And so we're teaching you to slowly approach things to build your confidence and to allow you to see that you don't have to be scared of this, that you can do it. I see we have a question about trichotillomania, so we will address that, but let's do a little more on ERP. And so I guess the biggest question is like, when we think about ERP, I know you talked a little bit about it being slow and systematic. What are some of the big goals? Like, what is the overall teaching goal of ERP, right? We're going to, first of all, a lot of times the question I always get that bugs me the most is, hey, I have a patient that has, this type of OCD and these are their obsessions, these are their compulsions. What should we do for ERP? And my answer is always like, I don't know. You should ask the patient, right? Because ask them what they're avoiding. A patient will tell you very clearly, if I didn't have OCD, these are the things I would be doing, right? These are the things that I'm currently avoiding. I'm avoiding going to a friend's house because I'm afraid they might have it, or because they have a dog, or I'm avoiding this route on my walk because there's a dog there. Like that is exactly what we're going to turn into exposures, right? We're going to get you, because if you're avoiding it, it often also tells us it's something you kind of want to do, right? That you would be doing if you didn't have this fear. So we're going to ask you and have you slowly do exposures that you're avoiding, but do them without rituals, right? A patient can touch a doorknob a million times a day if that doorknob's triggering, but if they go wash their hands, that exposure doesn't do anything. So when we hear people say exposure therapy is what works for OCD, no, it is not. It has to be exposure with response prevention because, again, when you conceptually understand CBT, if a ritual is maintaining the cycle, that behavior change of touching the doorknob won't actually do anything, right? It has to be full behavior change. Like I'm touching the doorknob and I'm changing my response. I'm not engaging in a hand wash. That's scary. I'm going to lean into my core fears. I'm going to, let the anxiety be there. And slowly and surely, the more I do that, the less I'll be afraid of it. So exposures have to be done with full response prevention and frequently. This is really important.
Absolutely. Okay, question about trichotillomania. Is it related to OCD? Yes, in the DSM, it is considered one of those OC-related disorders, BFRBs, bodily focused repetitive behaviors. You're going to use a similar approach. There's a question about, could this be medically related? Of course, there's always a chance that something could have a medical cause or etiology. So we do always, as part of your initial assessment, you want to ask the person if they've, been to the doctor recently, if they've had testing done to make sure you're ruling out any potential medical cause.
Definitely, right. But we do know that trichotillomania as well as skin picking, so any of those BFRBs do respond great as well to a CBT model with specific interventions for those. There's a newer intervention called comb that is really effective. Next question is, can you speak a little to the relationship between OCD and eating disorders and if ERP works for eating disorder symptoms and an example?
Yeah, so of course, you can have OCD and an eating disorder. They actually co-occur with some regularity. But it's important to know if the person is, especially if they're restricting certain foods or avoidant of certain foods, is it coming from an obsessive compulsive cause versus kind of your more traditional eating disorder concerns? The eating disorder concern would be more about weight and body image, or other people's perceptions of them. OCD cause, or could be something like ARFID, is more, I'm worried I'm going to get sick, I'm worried I'm going to choke, I'm worried I'm going to throw up, emetophobia, or this is contaminated, or what if I get someone else sick? So there's a lot of causes. You want to do a really thorough assessment, but it's interesting, the treatment of eating disorders is obviously different, but a lot of eating disorder treatment does incorporate exposure therapy
And
and
it's
ER.
still CBT based, right?
Exactly, exactly.
But we definitely don't want to be treating OCD as an eating disorder or an eating disorder as OCD, so this is where that diagnosis is so important. And as eating disorders obviously have a much higher medical acuity than OCD. And so even for us, if it is from OCD, right, we see a lot of patients, especially in the residential level, where OCD is something that is driving the weight loss and that is causing them to be in this nutritional deficit, but like we still have to get patients medically stable first before we can do ERP. Patients have to be medically stable in order to engage in ERP. And that's a question I do want to ask before we hop into more is like, even if someone has OCD, there are times where a patient with OCD, I actually wouldn't recommend ERP yet, right? I've never said I don't recommend it for OCD overall, but sometimes it's like, actually, I don't think ERP is warranted yet. A good example is comorbid eating disorder or like, medical acuity needs to get addressed first. But yeah, what are some of the others?
Yeah, for sure. If someone has an active substance use problem going on, of course you would want to get that addressed. Sometimes you can do it at the same time. It just kind of depends on the individual situation. Or if there's active suicidality, you would want to definitely get that treated first before you would attempt ERP, because we know ERP is going to cause distress on purpose intentionally. That's part of the intervention. And so if the person is feeling suicidal, actively suicidal, you would want to
Yeah.
pause on that.
And active psychosis too, because we do see a lot of comorbidity with OCD and psychosis, but the psychosis has to be managed before we can do ERP.
Yeah.
So next question is, can you give primary diagnostic and treatment differences between OCD and OCPD? This is great. I love this question.
Yeah, I think this is another one of those common misconceptions you hear where people will kind of, talk about OC and OCPD like they're very similar or there's a lot of overlap, when in reality they can co-occur. That's not uncommon, but they are, I want clinicians to think about these as two completely, totally, absolutely 1000% different things, right? OCD is a behavioral pattern that has nothing to, it's not attached at all to a person's personality. So we see people with OC with all types of personality traits. That really is just a behavioral symptom of scary thoughts, right? And ways that they're trying to cope with those scary thoughts, ways that keep them stuck, right?
And the behaviors for OCD are never functional. Like
Exactly.
this is really important. They're literally never functional. They're functional to reduce anxiety, but they're never functional in their life. There's no one with OCD that's saying, "Oh, my rituals make me a better employee," or right. I mean, sometimes they'll say with perfectionism just because it's like I'm afraid to address it, but in reality, they know it actually makes them worse or slows them down but these rituals are unhelpful versus OCPD.
OCPD is described the P in a personality disorder, like other personality disorders. It describes a personality profile of different, very specific personality traits that can become pathological in their expression, but they are egosyntonic to the person. So the person actually thinks that the behaviors they're doing are good, they're right, they're appropriate, they're the moral thing to do, or they're the optimal, efficient thing to do, and that other people should probably do those things the same way or shouldn't be bothered by the way they do things, but
And it helps them function better. They'll
help
talk
them
about
function.
that.
They're high
A lot
performance
of,
usually.
yeah, a
Yeah.
lot of surgeons will talk
There's
about in
usually
the
not
operating room.
a fear associated with, what would happen if you didn't do these things? Well, I don't, I want
Right.
to do
Why
them.
would I not do them? But there,
Exactly.
with OCD, it's this fear. Well, this thing could happen, right? There could be this negative outcome
Hmm.
versus yeah,
Yeah.
not a fear. It's just like, but that's how I operate. That's what makes sense. Or also like it helps me be more productive, right? Having my closet organized makes me way more productive in the morning to pick up my clothes for work than it would if everything was a mess and I couldn't find anything.
Yeah. And just kind of, anecdotally, and the research shows this too, but, if someone's showing up to your office and desperately wanting help, and you think, is this OCD? Or it's probably OCD. Like people with OCPD, if they come to treatment, it's usually because they don't
It's a
feel
big
like they
force.
want to change. Yeah, they have a partner, a spouse, or a work situation that's kind of demanding that they make some changes. They personally don't really want to do that and might even feel resentful about it. Whereas the person with OCD is suffering tremendously subjectively, internally, and wanting relief from that.
Yeah, and I mean, definitely scripts can be used in ERP, which is important. But Ryan, why don't you talk a little bit because you do a lot of treatment here when we have a lot of which we do, we get a lot of comorbid ASD, so autism, just autism and OCD cases here at the residential level. But talk a little bit about the common overlap and the diagnostic challenges, but also like how treatment might look a little different and what to expect.
Definitely, yeah. We see a lot of this. The research shows there is a lot of overlap, a lot of co-occurring autism spectrum disorder, and OCD. The most important thing is to really, again, going back to that really clear assessment is, as a clinician, you want to get a very clear picture of what behaviors and thinking patterns are associated with a person's autism versus what behaviors and thinking patterns are associated with OCD. And you again can kind of use that egosyntonic dystonic heuristic as a way to help you differentiate. Oftentimes, behaviors more associated with autism will help a person function, or they will feel good in the sense that they calm them down, or they reduce distress in a helpful way when they're in difficult situations. They're not necessarily driven by an obsessive fear or a catastrophic fear. They're more realistic things that they're stressors that they're trying to cope with. Usually the person will be attached to their autism behaviors that appear repetitive or frequent or almost compulsive looking. And so you have to really tease that apart. It's also very important that you get your patient to understand what is the difference between the two. Then they can kind of help you guide that and say, these are things that I like and that I want to hold on to and that help me. These are things that I'm terrified about and are really keeping me stuck and I want to get rid of. And letting them kind of lead that process through their own discovery of self and insight is really important. And some of the, even with ERP, we might modify it to make it a little bit more functional in the beginning to help a patient get buy-in. They might be overwhelmed by the idea that, hey, the goal is to let go of all your rituals. That might be a little too terrifying at first. We can start by just kind of modifying some of the rituals or moving more to judicious safety behaviors. And then oftentimes the patient sees, oh, I feel better when I do fewer rituals, and then
Yeah.
they might be more willing to let go of those behaviors. So treatment sometimes is a little more slow and gradual. Sometimes it's actually quicker. I've had, we've seen quite a few patients sometimes with autism
It
where,
clicks. It's like, okay.
yeah, they once they've kind of rewritten the rules in their mind around what's useful and what's not, they're able to let go of the OCD pretty quickly. It's pretty astounding. So it's a great population to work with. They have a lot of internal strengths, and we want to kind of use those to the benefit of treatment.
Yeah, I think one thing as a clinician just to think about too when you're treating autism and OCD is sometimes with autism there are still going to be some rules and rigidity in their life that they're not willing or like interested in letting go, and that's okay. Versus with OCD, we're trying to get rid of like all the rules and rigidity. So just be thoughtful of like what better explains this because don't get in that battle. That's not going to make a lot of sense. We'll take one more question and then we are going to wrap up just because I want to be cognizant of time. But what are some examples of supported response prevention? So not doing the compulsions that aren't white knuckling. Okay,
Oh,
so
this is your question.
this is my like pitch, right? Um, Response prevention often feels like white knuckling. When you think about response prevention, it's like, okay, do this exposure. So, engage in this activity or thing that you've been avoiding for a long time. And then we want you to not do a ritual. And in theory, when on paper, when you just kind of think about that as a patient, there's no way for them to do that without white knuckling, right? They're like, okay, well, then I'm going to touch this coffee cup and I'm going to just survive and keep going, right? But like they're still triggered, they're still holding on. And I like to give this example of if I had a patient with OCD who had this fear of throwing something valuable away. We can all agree that one of their exposures would be to throw stuff away, and the response prevention would be to not check the trash bag, right? That'd be great response prevention because maybe typically they would either go check the trash bag or go make sure they still have that valuable. We want them to not do that behavior. But if they take that trash bag and walk it to the garage and they leave it in the garage because they think to themselves, you know what, I'm going to leave it here just in case I need to check it later, or in case this gets too overwhelming, or in case something goes missing, what do you think ends up happening? Well, all day long, as they're trying to re-engage with life and they're with their kids or they're at work or they're doing different things, that thought about that trash bag keeps popping up. And the patients will come to us and say, I did ERP, I did exposure, I did response prevention, but I'm still triggered. All right, which means I'm still white knuckling. And I want them to see, well, yeah, what was the problem? The problem wasn't like the exposure or the response prevention. It was what you did after. You didn't actually lean in and let go. You still left ritualizing on the table. What would have been a better full ERP experience where you wouldn't have the option to white knuckle? Oh, I would have walked the trash bag to the curb and let it get hauled off. And when you ask a patient with OCD, yeah, so if instead of putting it in the garage, you walk it to the curb and it gets hauled off, what happens? And often they'll say, well, that would be a lot harder, right? That would be really triggering. And you're like, yeah, no doubt. Of course it would, because you can't undo it. But when it gets hauled off, what actually do you think happens? And every patient will tell you, honestly, like I would kind of feel relief because there's nothing I can do anyway. That, you guys, is the goal of ERP treatment. The goal of ERP treatment is, can we have you do it to a point where you are truly leaning in and you're letting go and you're saying to yourself, right? You're doing these behaviors or mentally kind of committing that like nothing I can do anyway. Like I've fully leaned in. And this is where we'll do a whole webinar on core fears because I think there's a lot of nuances around it. But like, what is the patient's core fear? What are they actually afraid of? Touching the doorknob is surface, right? That's not their actual fear, isn't touching the doorknob. It's something bigger, right? For me, I was always worried about, well, if I touch a doorknob and get sick that way, I could get someone else sick. And if I cause someone else to get sick or they died and it would be my fault, I can't live with that guilt. Like I wouldn't be able to live with myself. And so when I did doorknob exposures, it wasn't just about a fear extinction model of like, let's touch the doorknob till it's not triggering. We could do that, by the way, and extinguish that doorknob. But guess what? There's thousands of doorknobs in my life that are triggering. And that when we hear people say, well, ERP is exhausting, you have to do it forever and it just goes on, that's what they're actually talking about because they're using ERP as a fear extinction model versus using it as a way to generalize that anxiety is not dangerous and that they don't have to live in fear anymore and that they can actually approach the fears all the way. And so when we integrate core fears, by the way, we're still doing the same exposures, right? I'm touching the doorknob, I'm not washing my hands, but now I'm letting myself lean into the fact that like, oh, I'm really scared that I might get sick and get someone else sick. And you know what? Like, I'm going to choose not to figure that out. And I'm going to go cross-contaminate and do all the things behaviorally that would show that I'm not getting into that fear. And that would also show that like, there's nothing I can do anyways. If that does happen, like that'll suck, but I'll deal with it then. This is a super important piece, right?
Yeah, I think the way to really like summarize that beautifully is to say like when the patient is saying, I'm closing the door on the possibility of ritualizing,
Yes.
that is when they feel relief. That is when they get freedom from the fear. As long as they're keeping the door cracked on the possibility of going back and doing a ritual, they're going to feel the feeling of white
Yes.
knuckling. And so that's why a lot of clinicians in the beginning, they'll say, oh, I got my patient to delay the hand wash. But they knew in an hour I'm going to. So that's the most agonizing hour of their life. They're just holding on, waiting until they can
Right.
wash their hands. Versus if I say, I'm not going to wash my hands. I'm not going to do it. I'm
Taking
closing
it off the table.
taking it off the table, closing the door. Then they're able, their brain moves on.
Yep.
They feel the relief. They feel the freedom. So
I told our patients here this week in group, I said, my goal for all of you is that you actually get to a point that rituals wouldn't actually do anything. And they're like, what do you mean? I'm like, well, you're still going to do rituals in your life, right? If you have contamination, I don't want you to never shower. I don't want you to never wash your hands. But can that hand wash or shower never serve your OCD, right? Can it serve the function it's supposed to, which for people without OCD, it serves as just a hygienic function, right? That's why we do that behavior versus to reduce our anxiety. We have to take rituals totally off the table.
Yep.
So you guys just let us into our next webinar, which will be focused on like those nuances of ERP, the core, how we do core fears, how we address avoidance, how we address white knuckling, and what that looks like in practice, because those are all the things we love to chat and talk about. But Thank y'all for joining. It
Yeah.
is always so fun to share and talk
You guys
and
can see we could talk OCD all day long. We
all
love
day.
it. Yeah, I
Yeah.
hope this was beneficial, and we're really excited that this is the first of many future webinars from OCDI Texas. And so we're looking forward to seeing you again in 2 weeks.
Yes, couple housekeeping tips and tools. Go to ocditexas.com. We will have a section on the website that we're putting up that will focus on our webinars. And there will be a comments, questions, content section so that you can tell us what you want to hear, what you feel like would be useful, special guests you want us to bring on so that we can make sure we're giving you what you really need. But thank y'all for joining. So excited to work together and to continue to share knowledge and education with each other. That's the whole point.